Good afternoon. I am Sudesh Deshpande, going to speak on the quality assurance of the SBRT cases, essential challenges and pitfalls. I sincerely thank the organization committee and the team of the medical physics for giving me the opportunity to speak on this occasion. It's my always pleasure to come at the Tata Hospital and deliver my lecture. Spine SBRT. In spine SBRT, we have the high dose per fractions and we have the very small number of fractions. So patient safety and accuracy is very important. We have the critical structures, that is spinal cord, esophagus and stomachs. We have the steep dose gradient from the PTV to the PRV to the OR. Whenever we have the steep dose gradient, patient setup is important, as well as the choice of detector is very important to measure such a steep dose gradient, which will have the extremely accurate patient setup because we have the small CTV to PTV margins. And whenever we have the small CTV to PTV margin, machine QA is very important. We have the small intrafraction motion, that is a good thing, but there are some more complicated factors. The meter work for the fixation, so accuracy of the treatment plan is important. There are many times we get a patient with the re-irradiation, so dose to the target and OAR is a topic of the discussion. And tumors involved in the spinal cord, sometimes we have to accept the compromising plan. These are the things, something about the spine SBRT. Whenever we talk about the SBRT process, we had seen that SBRT process is very complicated, so we require the QA at every step, and it's a teamwork of the RTT, radiation oncologist, and medical physicist. When we talk about the SBRT QA, there are 4 types of the QA for the SBRT test, and these are 4 types of QA are very, very important, or I can say that these are the 4 pillars of the SBRT QA. So first and important thing is about the machine QA. For machine QA, we have the daily, monthly, and annual test, and this is well documented in task group 142. We do a patient-specific QA, we do a measurement for at point dose, and we do a planar dose measurement. That is well documented in task group 218. It tells how to do it and what should be the criteria of the acceptance. Then we have the E2E test, that is the end-to-end test, and should be done regularly. And task group 101 has given the recommendation that it should be done regularly. Then we have the external audit. There are 3 types of the external audit: level 1, level 2, and level 3. The level 1 audit, where we just do a output measurement. Generally, what we do in our country is a level 1 external audit. Level 2, where we involve the planning system and deliver the treatment and do the dose measurement. That is we check the accuracy of the planning system as well as the accuracy of our machine and the calibration of the machine. Then we have a level 3 external audit in which we check the system from the simulation to the end of the treatment. So there are many different organization or association have recommended for the audit, but unfortunately in our country we have the only level 1 external audit, but level 2 and level 3 are missing. Only those institutes they are taking the part in the RTOG trials, or those who are associated with the Novalis circle, they are doing the external audit. So we have the 4 different types of QA, and what are the problems associated with this QA, I'm going to discuss in one by one. For example, in task group 145, we have the list of the QA for a daily check, so how to perform with the time constraint. Task group 218 is only talk about the IMRT and conventional IMRT and VMAT, but it does not speak about what should be the criteria for the SBRT. TG10, there is no process how to do it, and there are recommendations for the audit, but who will do audit in our country, and how the common institute will get access to the level 2 and level 3 audits. These are some of the challenges. I'm going to discuss one by one all these QA processes in the coming slides. So about the machine QA, if you go to the task group 142, where they had mentioned the different types of tests. For example, we have a daily test, monthly test, and a weekly MLC or monthly MLC test. If you see this number of tests, there are nearly 15 tests for the machines, and we have the daily test for the imaging also. So there are nearly 20 to 25 tests we have to perform daily as per the task group 142. Then we have the annual QA. Now the question comes how to manage all these tests in a busy setup, because the machine is made for taking the treatment, not only doing for the quality assurance. So this is the main challenge. So this is not challenging only in country like us, but this is a challenge all over the world. So now there is a new guideline, AAPM RSS medical physics practice guideline number 9, which talk about the minimum required test should be done to for the SRS and SBRTC. So they had gone through the list of the task group 142. They found out that which are the tests are very important, that the failure of these tests can lead to the failure in the patient treatment, can cause the hazardous to the patient. So they had come out with some 8 daily tests from the 25 daily tests. Now we have the only test, but still performing these 8 tests, we had to have a 3 phantom, the set in this phantom, and believing on result, we require some accuracy of the set in phantom. So machine time is always constrained. So now how to overcome this problem? So one of the things now those institutes, they have recently got the true beam machine from the variant medical system. They have the option of the machine performance check. So what is this machine performance check? The machine performance check is the atomization process where all the tests, whatever mentioned, the task group 1 to 2, most of the tests are under the one plan. We have to just expose the one plan and we will get the results. So total time required to complete the machine QA is now 30 minutes. So 30 minutes time is not a bad thing. We can definitely spare the 30 minutes and we can get the results of nearly 25 to 30 tests. So atomization is the future. Now somebody may question about the accuracy of the machine performance check, the MPC. So this is the paper published in the Radiation Oncology Journal where they had compared the MPC result with our conventional test, what we do for the machine. For example, they compare the isocenter of the machine with the MPC, and the standard golden test for doing the isocenter test is the Wilson-Lewis test. So they compare the results and they found the results are comparable. So now to perform a such test in a busy department, atomization is the future. So we have to find how we can atomize our QA process so that we can save the time and we get good results. Now patient-specific QA. We know the task group 2 had taught about the composite dose measurement. That is, we should measure the dose in the same gantry angle or the crouch position. But sometimes because of the non-coplanar beam, we have to change the gantry angle and the crouch angle so that the beam doesn't enter through the electrons. And so we measure at the gantry 0. So we have the criteria for the VMAT and IMRT. And this criteria, we know that the 95% of the times the gamma should pass, and at least it should pass the 90% time. But these are for the conventional IMRT and VMAT. When it comes to the stereotactic rate of surgery, it does not speak anything about the specific thing about the gamma passing criteria. It only tells that the tighter tolerance should be considered. So what do we mean by the tighter consideration? It may be different from the different institute. So this is the gray area. So now the challenges comes when we do a patient-specific QA, the choice of the detector array and the gamma passing criteria. We'll just go through how the literature talk about these two issues. So now this is the paper published in the Physics Medica where they have done how the detector resolution affects the clinical significance of the SBRT pre-treatment quality assurance results. So what they observed, the detector resolution can significantly affect the clinical significance of the SBRT pre-treatment verification results. So definitely they mentioned that the choice of the array is very important, and the main important to the important thing that what they also observe that we should have the proper array resolution to avoid getting the false positive results. Means that our result may be the not correct, but because of the interpolation or because of the spacing between the detector, we have interpolated the result and we may get the correct result. So there is a good chances that we may get the false positive result. So this is another paper in the same line with the earlier paper where they had done the measurement for the SBRT patients, for the lung patient, spine, and the prostate cases. They compare the film results with the matrix and the map chart, generally what we use in our department for the conventional IMRT and VMAT QA. What they observed, the film had a gamma passing of 90%, but if you use the matrix and the map chart, our gamma passing percentage increases from 90, if you use the matrix to 93.5, and for the MAM check it's 94.9 for the lung. So when we use our conventional array detector, we get a good result, but it may be the false positive result. So we have to be very careful. So now what is the solution? Now this is the multi-institution validation of the new high spatial resolution diode array for the SRS and SBRT plan pre-treatment quality assurance. So this is the map check, the new SRS map check. They compared it in a different institute, and they found out that nearly 96 times the map check, the new SRS map check results are matching with the film results. So they have concluded that SRS map check can replace or can be used for the patient-specific QA to measure the planar dose. So film provides the excellent precision in terms of the dose resolution, which is the gold standard. It is cumbersome to use, time-consuming, owing to the uncertainty in the handling and calibration development. Typically, for SRS and SB QA detector array seen in the clinical use with having the resolution of the 2.5 millimeter. So we should have now two different QA devices. For one is for SRS and SBRT, and other for routine. So now the question comes, the cost involved in the both 2D array detectors. Not only that, with this 2.5 millimeter, we have the new detectors array available in the market from the IBA, which claims the resolution of 0.4 millimeter. Yes, we can have the 0.4 millimeter, but now can the institute afford to have a 2D array? That is another problem. So this is another challenge for the medical physicist. Okay, now we'll talk about what should be the criteria. Now this is the paper from the Duke University, which claims that the spatial resolution can be tightened to the 1 millimeter. Believe me, 2%, 2 millimeter passing gamma, about 90% is a challenge for a physicist. So we can reduce our tolerance, or we can tighten the tolerance from 2% to 1 millimeter, but is it possible to get a result? But if you go to the literature, and most of the leading university, the criteria for acceptance of the gamma passing can be 2% and 2 mm. This is a general recommendation. There is no standard guideline from any organization. But if you scan the literature, this is the criteria used for accepting the gamma passing ratio for the SRS and SBRT cases. Now comes the end-to-end test. That is E2E test. E2E tests are not common QA practice in the most of the clinic. The reason may be because we do not have phantom, maybe we do not have chambers or film, but it can be easily established with the existing setup, with the existing phantoms. E2E test is a step forward to mimic in the clinical scenario, so it should be ideally done. One of the advantages of the E2E test is the ability to have a clinical step involved in every step of the process. So in E2E test, we can get involved the radiation oncologist for marking the contours, and we can even get involved the RTT to treat the patient on the table, or to treat the phantom on the table, so that at the day of the first treatment, they will not see any surprises, and they will already know what is the process. So how to do the E2E test? The important is the selection of the phantom. The phantom should be easy to set up, it should be reproducible, and it should have the capacity to have a capacity to use it to do full E2E test. So when you do the E2E test, we should do the full workflow when we do a E2E test. That is, we should do the CT. If you are doing the MR also, do the CT and MR imaging, do a fusion, perform a contouring, then do a planning. Whenever you do a planning, ensure that the same complexity of the planning, what we are going to do on the patient, it should be there. Then do a imaging and treatment. So we should follow the complete follow the workflow when we perform end-to-end test. So again, it's not only the work of the medical physicist. Please involve the radiation oncologist, medical physicist, RTT in E2E testing, so that they are aware of the things about the QA process. So choice of the phantom, it can be non-anthropomorphic or it can be anthropomorphic. Ideally, we should have the anthropomorphic phantom. But the question with these phantoms are that the cost involved and the availability of this phantom. So resources is always issue in many countries. In foreign countries, we can get on the lease, but unfortunately in India we do not have the option to get this phantom on the lease or on the by paying for some days. We have to buy it, and which is very costly. So we can use the even non-anthropomorphic phantom. The advantage with these phantoms that the measuring instruments are inbuilt in this system, and it's become easy as compared to the anthropomorphic phantom. Okay, now we'll talk about something about the external audits. Dosimetry audits is a key component in the quality management program in radiotherapy, playing an important role in the safe implementation of the new treatment modalities and the technique. One of the strengths of the external dosimetry audit is the ability to independently verify and thus give the confidence in the new technique which has recently commissioned in the center. In ideal cases, the external audit should use the equipment and the phantoms from the external audited center. It means that even the chambers and the phantom, what we are going to use for external audit, it should not be from the same center. For time, it may possible that you have some chamber which has a wrong calibration factor, and you are measuring and you are commissioning this with this chamber, so you will not get any error. But if you use a different chamber, you can find out the error. Even the external evaluation of the result. Sometimes whatever the practices or whatever the process I'm doing to evaluate my result may have some error. But since I'm only exposing and I'm only doing the measurement, that may leads to a problem. So even the results will be evaluated by the third person so that any systematic error or any error in our system can be identified. So there are some audit performed in different countries. So this is the one Australian clinical dosimetry services audit they had done for spine and lung. This paper was published in the East Asia 2019. They did an audit. They exposed the phantom with the 24:2 fraction. They did a transverse film measurement, and they did a point dose measurement at two parts, one in the PTV and other dose measurement was in the spinal cord. So their criteria for acceptance was quite liberal. 5% 2 mm should pass the 95% or at least 90%. And the point dose measurement should be within plus minus 8%. That was quite liberal acceptance criteria. But if you see the results, gamma passing 5% 2 mm, there are few institutes failed this criteria, and whatever the even the 3% 2 mm, more institutes fail the gamma passing criteria. If you do a point dose measurement, if you see the results of the point dose measurement, even the 8% criteria, some of the institutes fail the 8% criteria, they fail the external audit results. And when they went back and when they studied the why people fail in the point dose measurement, they published a paper on this, and where they found out that it's the problem because since problem of the treatment plan system, they were measuring the dose in the bone and taking account the high density of the bone. Some of the planning system has a issue. When they did a Monte Carlo calculation, and then when they compared the result, they found that the compliance is better as compared to what they had done actually in the initial irradiation. This is another external result of the external audit. This was published in the Medical Physics Journal, and this audit is done in the USA, where the difference in the pattern failure between the IROC lung and the spine phantom irradiation. IROC is the new name of the RPC, and what they observed that there are two distinct pattern failure between the IROC moving lung and the SBRT spine phantom. The majority of the lung phantom failure were due to the localized error, whereas the spine phantom failure were largely attributed by the systematic dose error. What does they want to say? So this is the systematic error. You can see here there is a if you see the two curves, one is the institution curve and one is the film curve. What they observe, the isodose lines or the profile have the same shape, but they are separated. That is the systematic error. In the PTV, they also observe this error in the center image, in the even core region, and even the outside the PTV, outside the field of the plan. So what is this? This is the systematic error. Systematic error means this error may be due to the setup uncertainty. This may be due to not properly calculating the DLG or the MLC contribution, or not even not taking account the proper output factor. So this is the systematic error, and what they observe that whatever the failure were there, the 60% have the some 60% of the institute has some systematic error in their failure. So they raise the question about the accuracy of the planning system or the setup errors. So this external audit can help you to even evaluate your planning system configuration, and even if there is some error in your setup, that can be also identified with the external audits. So in conclusion side, machine QA is important but time consuming. There is no substitute that we can avoid the machine QA. So now to overcome this, automation is a need of the hour. We cannot go with our conventional way to perform the QA and treat the patients in a busy department. Patient-specific QA should be performed with the higher resolution detector array with a tighter acceptance criteria. So challenge here that the cost involved to have the two detectors array, and still we do not have a standard acceptance criteria for a gamma passing ratio. E2E testing is an important practice for evaluating the entire treatment process from the simulation to the treatment delivery, and should be performed in regular interval. Whenever we start any new technique, we should perform the E2E, and we should involve all the team members. External audits are the important component of the quality radiotherapy. As the complexity of the radiotherapy techniques and the technology increases, they become essential to ensure the safe implementation practice. So it's high time for our association, ROI and MP to come together and can lead for external audits for the whenever we start any new treatment or modalities or any new treatment techniques. Thank you.